So hello everyone and welcome to our session. So today we will talk about clinical decision support systems in regards of in regards of funding. So in the focus of the KHZG, and as we all know, clinical decision support systems are very expensive, but can also lead to true benefits in the end. But we will see today by Dr. Bess, who will present us the insights about the KHZG funding, in which way clinical decision support systems could be also invited to our clinical infrastructures and also for the benefit of the patients in the end. So I'm pleased to just introduce you, Dr. Andreas Bess here. So Andreas, I would say the microphone is yours, and we are all pleased to hear from you and what you have to talk about this amazing little talk. So here you go.
Thank you, Stefan. Thank you for the invitation to XtraTracks and to speak to you. Starting with an apologize. English is not my classical business language, and especially not in this under this suspects. I have a little bit of script, and I'm reading it loud from my script. So don't think I'm not looking at you, but it's not just my common and usual way to report on these things. So I will start some words with me and with where I'm coming from, and then go to the details and to the things. My name is Andreas Bess, and I'm board member of KHZG. We are a boutique healthcare IT consulting company based in Eppelheim by Heidelberg, and I also have some different works and workloads. So I'm also president of the BVMI, which is the Berufsverband für medizinische Informatiker, and several different kinds of institutions. I have some part in game. I would like to talk about the clinical decision support theme under the KHZG. This is not a technology topic which I want to report, but it's more about a strategy and governance topic. And let me start in this speech, and I want to leave enough time for questions and project, as we decided questions at the end, and especially questions on your experience in this area, because I think it's really important to talk about this and to get used to this new aspect of AI. I could be understand clearly. Everything is so good for the sound. Sound is good.
Oh, okay. Everything is completely fine here.
Okay, fine, wonderful. A few words about where I'm coming from, because context matters for what I'm going to say. The Prometheus AG advises German hospitals in hospital information systems selections, public procurement, digitalization strategies, and IT security. We think we are always independent and we are always vendor neutral. And I made I think about 300 hospital IT projects around in Germany and around Germany, German-speaking areas as Austria and Switzerland, which means I've sat in a lot of rooms where the strategy meets the contract and it meets also the clinical reality, which is totally different sometimes. That intersection means strategy, procurement, implementation. It's exactly what today is about. Let me show you the agenda for today. I will do it in 5 sections. The first 4 are content, and the 5th is entirely, I think, yours for the discussion. The main block 3 will be the procurement block. It's the heart of today, and everything else is context for it. And then slide 22. So I don't know not so much slides. I think we can start the discussion. Let's start with the founding theme. Germany spent 4.3 billion euros on hospital digitalization through the KHZG, which is exactly to say it's not German money, it's European money, 2/3 and 1/4 is German money. That's a number worth pausing on, but the question is how much was spent and especially on what. The KHZG defined 11 so-called Fördertatbestände, founding categories, and listed on the left side of the slide. And the one in the middle, FDP4, klinische Entscheidungsunterstützung, clinical decision support, is the one especially represented for this talk today. If we count the applications for this funding, we have about 9% of all applications on this special FDP4. And to make it clear, the FDP5, digitales Medikationsmanagement, digital medication, is also in the content of clinical decision support. So you can put this together. But just to compare it, the FDP3 is digital documentation, had about 1,500 applications, and the FDP2 is patient portals, which means it's the context between the outpatient and the hospital itself, has more than 1,100 applications. So it's not really focused in these, it's not really focused by the hospitals. Which means the hospitals spend the money on the pipes, I think, the infrastructure. The ZDS was afterthought, not a priority in this context. So where do these projects stand today? Just a brief view on it. There's a timeline, and the punchline is, I think, 2027, which means we have the contracts for this foundation had to be signed by the end of 2024. This is largely done, I think, by everyone. There are some federal countries that allow a little bit longer, up to 2025 and 6, but the majority just signed everything. And there is a penalty regime that started in 2025, and it's up to 2% per inpatient case if the systems aren't in use in special situations over the next 5 to 6 years. And the first proof of use requirements are this about utilization up to 60% at the end of 2026, about December 2027. It depends on your country you are in, federal country. So right now in 2026, we are in a window where systems are commissioned, but not clinical adoption is still being built, or sometimes it's not built. So we are in between, and nobody knows, I think, where which aim we reach, and if there is a risk for penalties. And this means commission does not mean equal life. That is the distinction of the general problem I'll come back to in some slides later. The funding logic, we started with the KHZG, and now there's another funding logic which started from the federal states, which means KHVVG. I will not translate the abbreviation because it's a very special German word, but it means KHZG founded individual hospitals. KHVVG asks a fundamental different question. What kind of care networks does Germany want? It's larger. It's not on a hospital focused, it's on networking focused. So KHZG meant project-based per hospital, focused on infrastructure-oriented themes, and this is winding down. And the KHVVG means holistic concept, service group assignments, new kind of services in hospitals, and it means regional care networks. in force now. Hospitals must declare their service groups and profiles by the end of 2026 or later. This is up to the ongoing acts for hospitals and for the healthcare system. The implication for the CDS means cross-sectoral decision support is no longer a nice-to-have feature. It becomes structurally necessary when the care model assumes multiple sites sharing data. So we are putting it wider, and it's getting wider. And KHZG should have built the pipes. KHVG asked what flows through them. Often the honest answer, we are not sure what will flow through them because a lot of things are underspecified and nobody has to get another funding to improve all the themes of the 11 Fördertatbestände. So let's have a look at what the hospitals are actually doing, just to get as a let's say our view on what KHZG created at the moment. If I had to summarize the current state of CDS in German hospitals in one sentence, it would be this: the infrastructure is there, the decision support layer is not. If you allow me to group it in 3 different levels, I would say on level 1, this is not an academic decision or a specification. We have alerts and rules, so which means truck-to-truck interactions, dosing alerting, contraindictions. This is widely developed and deployed in many hospitals, most out of the box from their HIS vendor or special vendors. On an upgoing level, we have guideline-based CDS for clinical pathways, order sets, structured documentation, which I think some hospitals are building this, but the most aren't there because they are not as structured in their documentation as they would like to be. And on the upper level, the AI-driven CDS with predictive models, everything we're talking today about is, I think, more a rare exception, mostly on university hospitals and research projects. But I have to make one important nuance to it. In the area of radiology and pathology, picture-based diagnostics, we are ahead of the curve. Those solutions are often device coupled and vendor supplied, and they are often not integrated into the clinical CDS layer overall. This is deployed does not equal integration, which means there are sometimes aisles with no connection to the rest of the system. So we have some kind of decision support, but we have not really a broad AI platform, I think, at the moment in German hospitals. So what was actually implemented when hospital applied for the KHZG founding? I think there is a persistent gap between what was applied for and what is actually in clinical use. And it's not unique to KHZG. It's a common effect I think we all know. Applied for were CDS systems in medication management for CDS components, interoperability infrastructure. Very basic on this level 1. What happens? CDS was added as an add-on at the end of the spec of all kind of specifications. Workflows left unchanged, and output is not integrated downstream from all systems. There's no scalability at very often the installations. And now there's a new wave, AI-assisted documentation, discharge letter generation coming in via vendor push, no strategic procurement. Same pattern as foundation as applied for give me money for it, installed as sometimes mostly as standalone, no integration and no feedback into the CDS layer. So we found it repeats the AI-driven options, repeats the same pattern as during the KHZG, and in the KHZG we didn't find any kind of this modern LLM-based cases. So whether it's KHZG found it or vendor pushed, the gap between deployment and integration is the same problem at the moment. So I think we have to talk about the technical prerequisite to close this gap between the installations and the use for it. So I think you cannot build a scalable CDS without interoperability. That's not a technical option. I think it's a logical necessity. CDS needs real-time data from multiple sources, from the KISS or HIS, from laboratories, from PACS, from medication, from care plans. If those sources don't talk to each other, CDS is flying blind. So we had this HL7 is a standard since several years, but FHIR is increasingly required in our tenders and especially in the KHZG, which I think is a very positive development. Without the KHZG, I think FHIR had much more problems to get a new perspective. But the implementation is highly heterogeneous. FHIR is mostly on paper in many hospitals, but not really in the systems. The vendor interpretations vary significantly between the different systems, and having an interface is not the same as having interoperability. So I think this is the real problem at the moment for the most German hospitals, to get a new definition of interoperability. Keep in mind, we'll come back to this. I will talk about this later on. And I think we need interoperability, but we think there are several additional components to get real good clinical decision support. So this was the introduction. We have this funding system. We have this funding elements, and then we have a problem because we had to get solutions. And this is, I will talk in the main character now about the theme procurement. Because the core argument of everything I'm going to say today is what you don't specify, you cannot enforce. What you don't have really written down, you can't implement. So you have to keep in mind that most German hospitals are public entities. They operate under laws like VGV and GWB. It's public procurement law, and this is not optional, it's binding. And if you got funding from public money, you always have, sometimes you have to follow these public procurement laws also, even if you're a private hospital or some kind of religious or social oriented. So the key implication is there is no renegotiation after the contract is awarded. What is in the tender document is what you get. If CDS is an afterthought in the tender, it will be an afterthought in the implementation. And procurement is not an administrative process, it's a clinical governance decision. The tender document is the most powerful clinical IT governance tool a hospital has. And most hospitals don't treat it that way. They treat it in a way to use it as a technical and a contract perspective, but they don't intend to get the clinical team as part of the specification and the procurement process. Which leads us to the problem, what means procurement and what kind of what are the three main challenges in the procurement process? First of all, let me just get a little bit deeper to procurement. I'm not really going as deep as it should be. but just to give you a rough overview. We have, before we get into this, a quick word on the legal framework. We have EU thresholds which define on the level of the European Union directives that were transposed to German law as the GWB and several things, and they have three principles. This means competition, it means transparency, and it means equal treatment. There are below thresholds, which is called UVGO. You don't have to remember it. There's some same principle. They always go on competition, transparency, and treatment, but they are lighter in their procedures. And for CDS and clinical AI, the most relevant procedure is something called Verhandlungsverfahren mit Teilnahmewettbewerb. It's a negotiated procedure, and it allows a dialogue with the bidders before final offers. This is an essential for complex and innovation-heavy requirements, which you can't specify starting in every single point, and you have to develop together with the vendors and the solution. For genuinely novel solutions where no finished product exists, and this is some kind in the AI area also, there's also some way of calling Innovationspartnerschaft, which is a special article in the GWB, which allows you to go in a co-development on a legal compliant process. But the key principle is always you have a so-called funktionale Leistungsbeschreibung, which is a description of what you want to get, which describes output, outcomes, and no products. You can't specify a product. And now we have a problem with the AI. I can't specify, I won't use the product A, B, or C. I have to specify what the product has to deliver, and then there will be bidders for this solution. And at the moment, there are sometimes in the AI area, very specialized products where only one vendor is with a specialized product. So this is a real problem for the procurement. No brand names, and mostly the economically advantageous tender, including life cycle costs. So we have also to look for the total cost of ownership of the product, including from the start to the implementation till the end in the service. Which leads us to the problem to be competition, transparent, and equal. We have to do specifications, we have to do evaluation, and at the end we have to become an assumption. And I think this is the one I want to go in, the challenge number one, writing the specification. The first challenge is the most fundamental, I think, how to describe intelligent in the AI content in a legally binding document. Technical specs describe products, not outcomes. The system shall provide CDS functionality is meaningless in procurement law. It's a blank check to the vendor. So the solution is functional specification. Describe what the system must achieve, not what it must be. Define clinical scenarios, what decision must be supported, when, with what data, in what workflow steps. Everything must be verifiable, either through a live demonstration, a defined test case, or a reference installation. I have a simple example on the slide. A technical system shall support truck-to-truck interaction checking, which is a useless specification, I think, but it's commonly written down in tenders. I think we need a functional aspect, like a system shall alert the prescribing physician in real time if a prescribed medication conflicts with an active indication using patient-specific data from the medication record, which means much more and has much more problems for vendor to deliver this complex solution. Which mean functional requirements to describe goals, technical requirements to describe products, and CDS only goals can be enforced, I think. And this is one of the first challenge I think everyone has to get the specification on decision support and on the AA character. Second challenge, I think, is designing the evaluation metrics, especially what to evaluate to get a real innovative solution. Even if you write a perfect specification, you can still get a mediocre outcome if your evaluation metric rewards the wrong things. Procurement law requires equal treatment of all bidders, but CDS quality is not a binary yes or no. It has depth, configurability, clinical sophistication. So price-dominant matrices produce lowest common denominator solutions. You get the cheapest box that ticks the mandatory requirements. I think that's not what we want. So I think there are 4 criteria worth waiting. It's clinical depth, it's decision transparency, it's workflow integration and scalability and openness in one word, I think, which altogether mean much more than just yes or no decision support. And you have to use all the 4 dimensions, I think, for a good evaluation metrics. And the most powerful tool, I think, is to use to implement and to demand use case implementation as evaluation scenarios. No feature checklist, no feature fucking. Ask the bidder to demonstrate live on real clinical scenarios what you have defined. That makes an evaluation comparable, objective, and legally defensible. But you have to get these use cases, which means you have to get in contact and involve the clinical team for this. Short point means what you measure in the tender is what your market will be delivered. You get the answer, what you measure. If you don't evaluate things, you will not get these delivered. Third challenge, and this is, I think, a really big one, is the challenge of the contractual anchoring. The third challenge is one that most hospitals discovered too late, I think. Winning a good tender is not enough if the contract doesn't protect what you bought. Without contractual anchoring, the vendor controls the data, the vendor controls the logic and the updates. What isn't fixed in the contract can be changed, restricted, or repriced later, which means development on further features. No, you buy it again. I think there are 4 contractual must-haves listed here from 1 to 4. In the area of interfacing, in the area of data portability, in the data of update obligations and the scalability rights. In the interfaces that are mandatory, versioned and documented, I think that you can't have, we talk about it, I think we shouldn't talk about it. The export obligations in structured machine readable formats, I think it's also a real important thing. If you got to there will be a point that this system will be a legal system and have to be changed to another one, and you want to get the data at least at this point. So the evidence base must be maintained. This is on the scalability rights. The right to extend without full re-procurement. Today, you're thinking about one hospital. Tomorrow, you are thinking about, as I mentioned in the KHZG content, a network. And then, what does it mean in licensing, in scalability? And the problem is, if you buy it then again, maybe it's much more expensive. So, and one often forgotten point is who owns the clinical data repository, who owns the really database, who owns the accurate clinical data that the CDS system generates. This must be in the contract. At the moment, we have hospital information systems based on Oracle databases, which means this is a special licensed encapsulated database, and there is a big discussion if the hospital has the right to get the data directly on the database without using the hospital information system. So this, I think you have to keep this in mind to not to repeat this this error again in the new area of artificial intelligence and clinical decision support systems, because you put you output also in the clinical decision your own knowledge, I think. So let me show what this 3 challenges and the way looks like in a practice. I will not really bring you in a real practice, but it's I think it's just to describe how we did it. I want to show what a real CDS requirements catalog looks like, anonymized and but from an actual project. The content is, it's a maximum care hospital, it's a radiology context, a new care program with a new established market solution. It's for lung cancer screening. It's a public tender. It's a negotiated procedure, as I mentioned before. And we structured the requirements in 3 levels, and a mandatory and it's an optional in the use case level, which means that we have pass and fail requirements, we have scored optional requirements, and we have live use case demonstrations to evaluate the real working area. There's mandatory components are real data access, the FHIR interface, structured output, it's non-negotiable. The optional tasks like platform scalability, regional connectivity, research data export, just innovation and innovation possibilities. And in the scenarios, we have structured first and second reporting. Remember, it's on screening. We have risk prioritization, workflow integration, and demonstration in the live. And what was very surprising for us is, as I mentioned before, you ask and you evaluate and what you get. You get what you evaluate and what you ask for. We expected a focus point solution, focused on the special use case we asked for. And we received platform approaches, workflow embedded, AI, cross-department decision logic, strategic scalability. So, of course, we used evaluation methods which enforced the vendors to deliver complexer systems as just a single solution for lung cancer. And this, I think, is just the range. As you ask and as you evaluate, you get bigger solutions. And sometimes you get surprising solutions, which means a well-designed tender doesn't just select a vendor, it reveals what the market can actually do for you and ask for it. So let's look at what you could do wrong, the procurement traps. I think there are 3 big mistakes hospitals make, especially on CDS, and maybe I can show you how to avoid them. I don't know. I think the first mistake you can do, you think CDS as an afterthought. You add it at the end of the tender. There must be also some kind of CDS or IE. You make it a core requirement from day one. Make it part of what you require. Second mistake is, I think, technical instead of functional specification. Don't describe it as technical, describe it in outcome-oriented requirements, in use case scenarios and live demonstration. And the third one, no acceptance regime for CDS functions. System goes live. CDS features never activated or testivated. The fix, contractual acceptance criteria, defined test cases, staged sign-off. We find it very often that there is some kind of CDS function part of the tender and its board, but it doesn't come to life because nobody is behind it. And it's, everybody knows, let's do it tomorrow. I think there are not procurement mistakes. I think there's a clinical governance mistake. The procurement team can't fix them alone. This requires clinical leadership in the room together with the procurement team. The clinical part must be part of the procurement team to close the gap between what you describe and what you will implement afterwards. And this, I think, is at the moment a real big problem after the KHZG Foundation and founding and what they have to deliver in the next 12 to 24 months. Let's have a look where it is all heading to. I think this is sometimes, so it's a little bit of a guess, I think, but it's a guess on what we now find in the market. The shift from the rule-based AI, the CDS, is already happening. As I mentioned before, there's a new wave. The question is whether hospitals are positioned to benefit from it or not. I stage it in three levels. Let's say the rule-based stage is the conventional explicit if-then-else logic. It's deterministic, it's transparent. This is what most hospitals have today in contract interdiction and things like that. A model-based kind of AI with pattern recognition, probabilistic outputs, use case like sepsis prediction and things like that are on their way. They are on their way in special systems and they are emerging. But this is very, very specialized. And now we are on the stage of the LLMs. We have the context-aware guideline, integrated patient-specific narrative support, and we have early pilots. I think it's mostly research or in the area of research and on the way to the clinical. The prerequisite for any of this, I think, is a clinical data repository. Structured, longitudinal, machine-readable patient data. This is a missing layer in most German hospitals. Without this clinical data repository, CDR, I think AI-based CDS is a proof of concept and not a clinical tool. And that is one we really miss at the moment. We have a lot of hospitals with a monolithic architecture, and which means you can't connect any kind of AI in this monolithic architecture if the vendor doesn't allow it. So if you will find a solution to this problem, you have to implement new kinds of data repositories and new kinds of coding and structured data. There's an additional point. It's a regulatory reality. The clinical AI is a high-risk system under the European Union AI Act, Annex 3. It needs conformity assessments. It needs transparency obligations. It has mandatory human oversight rules. So if you are procuring CDS now, AI Act compliance must be in the tender from day one. So we have another complicated part, which has to be part of your procurement procedure and part of your governance. And I think this is some hospitals are a little bit afraid of this, and which will not empower this team, the CDS team. Let's have a little look, but only a little on this regulatory stack I mentioned. I think we have the, I think there are 3 layers, I think, for every higher risk clinical AI. And all of these apply simultaneously. This is not a pyramid. It's a very, very complex regulatory system. So we have in Germany the MDR, MDPR, and the IVDR, which CDS software is typical class 2A or higher. This is a starting point. Clinical AI doesn't exist without it. We have a second layer with the AI Act and these all kind of high-risk obligations, which are defined now and which are will kick in, will be obligatory in August 2026, which means in several weeks. If you are procuring clinical AI, this is not a future problem, that's a real problem. And we have a European aspect also, the data layer, the GDPR and the European health data space, I think, which is a special part, I think also for the GMDS, the lawful processing and cross-border secondary use, which I think 90% of German hospitals don't have on their agenda. So the key point for procurement is you have to keep in mind the AI Act, which defines conformity evidence to fold into the existing MDR conformity assessment, no duplications, but you need to plan for it explicitly. And one more thing, I think this is a moving target because I think it's a digital omnibus on IA from the late 2025 and the 2026 proposal to reclassify medical device AI may shift some of these dates. I think you can't rely on these regulatory points, and you have this regulatory uncertainty at the moment, which is in itself a governance risk. So, what is, if I said we have clinical networks, I mean that it means to CDS beyond the hospital walls, that there are additional points to implement regional networks and cross-sectoral care, points directed to the future where CDS is not confined to the hospital walls. We have the theme of the electronic patient 3.0, a longitudinal data foundation, which is mandatory for the outpatient physicians. And we have the problem that the data quality, I think the data quality is a real Achilles heel in all systems because cross-sectoral CDS is only as good as the data it receives. It's also in the hospital, the same problem. The ambulatory sector is largely excluded from the hospital IT integration today, and the EPA adoption at scale is expanded 2026 to 2028, and CDS use cases come later. So I think there are no drivers for anymore at the moment we can rely on. The message, the foundation is being built, but the CDS layer must be planned now, not to retrofit once the data is there. The same problem as the hospital interwards problem, as we mentioned. So, to come to an end, in some way, I would like to talk a little bit about persistent challenges. I think there are some persistent challenges, especially I think maybe 6, maybe more. We have to accept and to cope with. I think there are 6 barriers that are not the amount of funding. It's not technology or regulation. It's different things. I think it's heterogeneous IT landscapes. We don't have similar structures between hospitals. This is the fact we have to accept and to cope with. We have the formally mentioned data quality. CDS is only as good as the data. Incomplete records, missing coding, inconsistent terminologies, I think are a really problem. The workflow integration, I think, in the hospital workflows, alerts with alerting not really embedded at the right point. It's a clinical design problem, not a technical, but it's a really barrier because it doesn't help in the workflow. Which leads me to the user acceptance theme, which means alert fatigue, clinical distrust, and change management. The human factor decides success or failure, I think. Proof of benefit, demonstrating measurable clinical economic outcomes is hard. It also is the only way to secure budget for the next phase. Stefan mentioned it at the start of the discussion, and if I can give some proofs, I can't at the moment. I think there's a lot of studies international, but I don't think that we have in Germany really the proof of benefit of CDR and CDS. And we have this very, very complex regulatory compliance theme in the stack of growing MDR, EU, GDPR, EHDS, NIS2, and so you have all these things keep in mind because they will overrule your existing solutions. So, ending with all these themes, I would talk about the last barrier, I think, and I think this is the more barrier that I put above all others. It's one of the least one, and then I will finish the discussion. I think the shadow AI is already in the hospital. The staff is using AI tools for documentations, for literature search, for drafting clinical letters, without any institutional approval oversight. And this is not theory. I think it happens now. There is the AI Act, which requires competency obligations, which means that you have to do it, and your staff must be trained on AI, and this applies today. So the answer is not prohibition, it's structured governance. AI safe zones for experimentation, formal approval frameworks, clear accountability. I think this is a message we have to put in the scene. And the procurement connection. Every CDS tender is also an AI governance decision. What you buy defines what you govern. If you don't specify governance requirements in the tender, you won't get them. So which means governing clinical AI is not an IT task. I think it's a board level strategic responsibility. It must be implemented in all kinds of decisions. So coming to the closing and hoping that I could get you on at least 3 takeaways. I think infrastructure is necessary but not sufficient. The KHZG founded the infrastructure. Most hospitals are in some kinds in level 1. They are doing some kind of clinical decision support, and the decision support requires intentional design, not just money. I think the second one is CDS must be designed in the procurement document, not retrofitted. You have to implement it from the start on. It must be designed when you don't specify, you cannot enforce functional requirements, use case scenarios, interoperability clauses, acceptance regime. All of this must be in the tender from day one. And AI is coming. Governance and the data quality decide who benefits. LLM-based CDS is real and advancing, but without a CDR, without integration on FHIR-based standards, without governance frameworks, it becomes another expensive silo, I think. And this, I think, we have to keep in mind very, 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 very directly. So now I will come to the end, and I'm looking forward to the discussion and you ask your questions and comments. There are 3 proposals for the talk. I don't think we have to go through them. It's just for intending something.
Thanks a lot, Andreas, for this interesting and very special talk here in regards of the depth of some problems, but probably also some advices for the future for all of us. So for all the audiences, I would say, so you can use the chat, but also you can unmute yourself right now if you have any questions. So just feel free to spend the time with Andreas and us to come up with a cool discussion here. So are we having any kind of questions right now? Otherwise, I will just start with the first one. So Andreas, as you mentioned so far, so a big key for the challenge to come up with a good clinical decision support system in reality might be the part of interoperability. So in another way around, I would advocate, okay, if I don't have a very interoperable architecture right now in my hospital, so probably I could start, for example, with standalone systems in the end. So would that be a good advice here, or what would you say?
I follow your explanations in total. I think without interoperable design and architecture, you can start with standalone systems. You get some experience, you get used to it, but I think in the end it will cost more if you start and afterwards to reintegrate the systems, and there will be the need for reintegrating this. And at the moment, if there is no interoperability architecture, I think you are very, very, very dependent on the vendors, on your partners delivering the systems. You are on part. You have to ask them to help you, and I think normally this is expensive.
Okay, so there I can absolutely agree here with you. So perhaps a little question here in the next step. So as you mentioned it in the start of the talk, so the KHZG right now gave us a lot of money on the end. So all the hospitals came up with the opportunity to get the next step into digitization in the end. So perhaps for the special topic, clinical decision support systems, I would just ask the question, was it too early here? I mean, when we are talking about very heterogeneous architectures right now in hospitals, and right now we are just trying to, I would say, claim to have better architectures, better infrastructures in the end in our hospitals, was this claim of integrating clinical decision support system and especially AI systems right now a bit too early here?
Mm-hmm. I think in preparation of this talk, I thought right at this point, I think it was too early. It was too early in the scope of the hospitals weren't at the point of real digital information. They are totally paper based. They got with the KHZG a huge step forward to digital patient records. And there was no idea how you can implement clinical decision support because there was no clinical data you can decide on. And now you have more digital patient records. You have nearly 80 to 90% digital data. I would not say it's structured data, it's digital data. And now they start to think about it with a new wave of new AI products with LLM models and things like that. And this is, I think, this wave is after KHZG. And there's one big design problem in the KHZG because these Fördertatbestände, diese 2 to 6, are under punishment. If you don't implement and you don't get it in real use, you get this discharge of your case which means you have to have a solution. And what did they do? They took medication and interaction check as a decision support solution. So there is no really decision support, just interaction check. And the money was, they got some money for it, they spend the money, and now they are ready. And now the next wave comes and starts and says, now we can do much better, much intelligent, much AI. But they implement it in their core systems as the core systems are. So the monolithic systems are still the monolithic systems. So we have some kind of we made fundaments, we made the infrastructure, but this infrastructure was not designed to be open for artificial intelligence and decision support. I think there's I think there's a discrepancy in the KHZG between this FDP4 and the rest.
Okay, thanks a lot for this. Yeah, for this opinion. So I guess in most ways we have big problems here in Germany to come to a very harmonized infrastructure all over the hospitals. So I'm not too much sure, to be honest, if the second wave, so this next cornerstone, so to say, for the next funding will end up with there was this benefits what we are searching for in the end. But enough from my side here in the end. So perhaps some other questions from the audiences here. Do we have some?
Okay, I have to say the second wave is a wave from the industry. It's the industry wave. It's not with there's no money in the system for it at the moment, and you won't get money for it if you don't have complex projects to cooperate with other hospitals and the outpatient area. So I think this is the real problem. You got new tools. There are new tools. There are a lot of new tools, and they are not so expensive, but they are not cheap because they must be integrated. And at the moment, there is no new money, but you have new solutions, and you have to move as a hospital, and you don't know where to move.
Okay, but I think that's also a very explosive bubble, I would say, also for the industry in the end. I mean, if there are right now the cool solutions, but there is no money nowhere, then probably some industry partners and companies will just die and without any effect anywhere. Oh my. Okay, so are there any questions from the audience? So I have a bunch of questions. So no matter what way, we can just fill the time here. So if I can, and let's have another time here with a question. So what I thought is, okay, right now in the hospitals we had this big wave of digitization aspects which just waved into our infrastructures right now. So probably a lot of us know, okay, you can just move in digitization if you have the manpower in the end. I mean, all of us know, okay, personal stuff is quite also expansive in regards also to the technical parts. So probably I would raise the question, okay, when I right now come up with those cool AI solutions in the end, are we as hospitals, especially in the IT parts, are we already prepared for that? I mean, we need this manpower, we need obviously the interfaces into the systems, probably we need governance aspects like, are we in a cloud or are we on premise? And we also have to talk about this other aspect, what I just want to raise in my next question. So just a little cliffhanger here. I also have one aspect about the data in the end. So what are your thoughts about that? So what are your experiences?
Yeah, I think the IT is also not at the right position at the moment because they cope with the regular standard problems and have to think about this new problems in artificial intelligence. And you mentioned things like cloud computing, like service-oriented SRS models, new licensing models, how to pay for it. You pay by you don't buy your AI license, you pay for the use of it in tokens. What is a token? What means a token to a regular patient case? Nobody knows. So I think this is the real problem at the moment, that there are a lot of problems you have to solve in the real day business, especially in compliance regulatory affairs. And you have to look for this new part. What I think the medical, the clinical part has an easy position for it. They look for it, they see it on their congresses and their talks, and they think, oh, we need it, we can use it. And I think this is, and on the other hand, you have, I think, outside the university hospitals, there is less know-how. There's very less know-how. Even, I think, don't mind, even in the university hospital, I think there is a growing know-how, but it starts from now on. And I think this deficit in know-how, the omnibus of regulatory affairs, which is driving very fast and is very big, the truck of new acts and new laws you have to follow, makes it really difficult at the moment.
Yeah, I can absolutely understand that. So perhaps
I have a little more comment. I think it is related that you said before that one of the important things is there is a missing layer. That is the clinical data repository. And normally when we are working here mostly with the structured data and so on to make the machine learning models and so on, but this is really an issue, the data. And how, in your experience, how imagine it can be work at the best to make a some real clinical data repository? So I mean, between the different hospitals, data heterogeneity, missing data, how imagine it could be a better or a first step to really receive or have this longitudinal data that is required for the training of the machine learning models?
You're focusing on the learning aspect, I think,
yes, exactly.
as peer data. I think this is, I think, in the regular hospital community, nobody thinks about this problem. They think they got the data, they got the solutions which are trained and everything is usable. I think this is a problem for Germany. I think this must be on the university hospital level. I think this is maybe from the Medizininformatik Initiative, another thing you can restart. I think at the moment the Medizininformatik Initiative at its end, as I know. So maybe this should be part of new research activities on this, because at the moment I don't see it. I see the electronic patient record for the GKV-Patienten, and this data is allowed to be used for research, but I don't know if this is usable for the part of the machine learning. I don't know. But as the hospital, for most hospitals, is nothing they discuss.
Okay, thanks.
I think it's a very interesting question. Maybe it's a question you discuss all the time, but I think thinking about Germany want to be at the top position of AI development, this could be, I think, a kind of European or very special new big project on medical informatics and building up such peer databases on training databases. I don't know, are there any initiatives at the moment in this area? That's really interesting for me, just to.
Well, we have the medics, no? Then data integration centers in theoretically that is a network to collect, but there is not so easy as it should be, and therefore I thinking in other alternative or how do you see it, that?
What I see is that several federal states are implementing some kinds of data repositories on state basis. As I know, I think Baden-Württemberg has the Medicus project, and Bayern is implementing some kind of parallel patient data collection despite the electronic patient record from the GKV. I don't know. I think there are some very. I can't. It doesn't. Well, but that's what I read.
Thank you.
Yeah, thanks a lot. So Mrs. Pepler also brought us one link about the medical informatics initiative for those who didn't know all this so far. But perhaps I can just stick to this question of Zuli at this point. So the clinical data repository is, for example, one thing what we also implement here right now in Jena, for example. So what I would want to discuss about is about the aspect you just mentioned, just one in one little sentence in the end, but I think it is very crucial in this regards of using AI. So who is the owner in the end of this new generated data in the end?
Yeah.
So I think this one question is one really big one, because obviously when we are using, for example, software as a service, so like a cloud computing AI or whatever, or even if it is on premise. So in the end, I would ask always the question, so who is the owner and who is also responsible, for example, in regards of what happens afterwards? So this is one crucial part, and I would be amazed about your opinion, about your experiences, what you had in discussions with also the vendors and stuff.
There is a really, I think at the moment it's technology driven, the problem, who is the owner, and to widen it up, I think on which data you can rely on, which is reliable data. It's from whom and who changed it, how reliable is it, in which context is it representable, on which coding base it is. I think this is a real problem for the vendors at the moment, of the big systems, because they have old systems, they have old database structures, they rebuild their database structures, and they have to cover with this old installed base, which is in some kind unstructured or structured. Nobody knows. It's very. It's a convolute, I think, of data. And at the moment, I wouldn't, in a normal hospital information system, I wouldn't rely on the information to do clinical decision support, because I think they can't reproduce the data and the consistency of the data. But it's a personal opinion. It's a really personal. Officially, they are used to everything, and they have all kinds of protocols, and of course the data is unchangeable and no. What we have at the moment is, if we change hospital information systems, which is at the moment a big wave, because we have end of life from several products like ISH or ISH Med. We have a really problem for data migration. We can't migrate data from the legacy system, ISH, ISH Med, to the new systems in just a small part of it, let's say the administrative part of it, but all clinical data is a real problem.
Yeah.
So if you prolong this problem, I think there is no really good data at the moment. And if you start with a CDR, I think you have to start from scratch on and be very, very restrictive. And this grand idea, just put everything into CDR, the AI will cope with it. I don't think this is the solution.
Yeah,
it's a big dream of medical informatics. Just get the data and process it. I think this is something that wasn't true for the last 20 to 30 years, and medicine is too creative and too human science, as they can. You can say everything in this real data portfolio is worth to be processed and to interpret it.
Yeah, I can absolutely.
I think it's a really problem, and it's a promise for the future at the moment. And all vendors of CDRs are promising we have the solution problem. There's no problem. Just give us the data, put it in, and we will leave it structured. I think the data is not in the quality at the moment.
Yeah, thanks a lot here for this part though, but I would be a bit more harsh, to be honest. I would say, well, I think we need the next step here. The next step, for example, also for audit trail, and also the next opinion about metadata in this regards, because obviously, even if we are just putting all the data what we have in our clinical decision support, in our hospital information systems, into these CDR systems in the end, but in the end, we also need some kind of idea where this data in the end, or this new information comes from. I mean, would I rely on the generated data based on an LLM in the end, or is it the opinion, or is the idea of a doctor in the end? What exactly is this new data which was generated here? And obviously also the audit trail. So who perhaps also had some kind of influence into this action to come up to this data in the end. So I guess this big ball of questions of also legal aspects in the end. I think there are a lot of unanswered questions right now, especially from the legislative and in the end here in Germany. Obviously, we have a lot of legal aspects, but I guess in parts of digitization, we are, I say, not blind, but perhaps just one-eyed, I would say.
Yeah. Sometimes I think we are too critical to digitalization, and we are our own problem at the moment. But a little bit more active control, governance to this to the clinical decision support, I think would be really to appreciate. And active governance in the hospitals, just to get ahead of the problem, and not just to run after and say, okay, we buy everything we find in the market and everything is good in the market. I think this is a real problem at the moment, and this is maybe a German problem, because Germany, well, we are still using the fax. And hey, I'm still getting.
Don't push against the fax. That is the only thing what is working.
Yeah, I'm still getting orders from hospital by a fax. So God save, we have a fax at the moment. it's
at least the only thing we can rely on.
It's funny, I think, on one hand, but this is a problem. I think maybe, as you asked, was KHZG to the part of clinical decision support, was it too early? On the other hand, it was too early, but on the other hand, thank God it was so early that Germany has to think about it. German hospital started to think about the problem.
Yeah,
without
I absolutely agree.
Without funding, they wouldn't have thought about it about the last 3 years, and it would be even worse now.
Yeah.
And the discussion of interoperability and the discussion of data repositories, I think this was was empowered by the discussion for clinical decision support. I think maybe it's the wrong way around, but it gets a way around at the moment.
Yeah. So I think a discussion is better than non-discussion here. So that is indeed the place here. So regarding on the discussion, so what I didn't see so far are more questions in the chat. So perhaps this is the last chance here for you before we're closing the session to raise last questions, if you have some. Otherwise, Andreas, I would say thanks a lot for your time, for this interesting talk, and all the audiences, thanks a lot for your time. So we will stick to the next session. I guess it will be in next week already, no? I just have to... Okay.
Yes, next week, and it will be very good. This is complementing is about an AI Act. And you are all
great.
Great.
So perfect timing here. So afterwards we came up with some big questions about the AI Act. So next time we get the answers. So all of you, thanks a lot for your time. Have a great evening and see you next time then.
See you. Thank you. Thank you for the audience.
Thank
Bye.
you. Bye.
Thanks. Bye.